Hello, this is Professor David Bishai, and in this lecture on quality, I wanted to cover two important things. First, I wanted to cover the dimensions of quality, how we measure it, and what they signify. And the second thing to cover is government interventions to try to improve quality, why there is a market failure that will always require government interventions. We'll cover up some of those strengths and weaknesses of approaches. First, a reminder why healthcare quality becomes so important again and again. The first reason is uncertainty. The second reason is information asymmetry. In healthcare, consumers cannot assess quality well, and they are vulnerable to potential exploitation. And providers are uncertain too about which services would produce the most quality. Because consumers cannot be their own guardians of quality, they need help, and someone else other than the consumer and the provider needs to be in the system in order to help quality happen. So the first principle is that measurement is going to be required. We are going to require some type of measurement as the foundation for quality improvement. Since we want to measure quality, let's talk about the dimensions of quality that one has to measure. We go back in measuring the dimensions of quality to Avitus Donabedian's trinity. The trinity of quality dimensions is still how the field thinks about quality. The three elements are structure, process, and outcome. Structure means who does what are their certifications and qualifications. Process is about the things that get done. What was done, who did it, and what was happening when it was going on. Outcome is what happened to the patient's health, what happened to the patient's body. Was there a death? Was there a complication? Was there satisfaction after the healthcare event occurred? When we talk about measurement, structure measurement is often something that's done on a static basis. It is done using snapshots of what is there in the system on any given day. In structure measurement in hospitals, the Joint Commission on Accreditation of Hospitals is a very important entity. This is a voluntary payment that hospitals make, and they pay the JCAHO to accredit their hospitals. To be accredited, the JCAHO will review documents, it will come on site to the hospital, it will interview staffs, asking about elements of structure. What are the credentials? What are the written policies? Do the staff seem to know what the policies are? Is there dirt? And so on. So structure measurement is often done by reviewing the current status of what is in the system. Process measurement is harder. In process measurement, we have to be watching the activities going on. We have to look at some data. What percent of patients got this treatment or that treatment? What percent were immunized, counseled? Did the staff wash their hands? Did they take temperatures properly? To collect data on what is happening, the measurement enterprise has to actually get into the process of care. So one initiative here is called the Physician Quality Reporting Initiative, PQRI. This was a voluntary Medicare program started in 2007. To participate, a doctor would choose 3 quality indicators for their practice and report them to Medicare. And you could choose from a menu of things you wanted to report to Medicare. You could pick, I want to report on the number of my heart patients that I prescribe aspirin, the percent of people over 65 I've given a pneumonia vaccine to, percent of smokers I've advised to quit. And a doctor that enrolled in PQRI would get a payment from Medicare in order simply to report. So they were paying to report quality. And doctors would use this money. They would often hire a vendor to give them software that would automate collecting and reporting these quality measures. So the PQRI, it's interesting that the incentive wasn't to change the quality indicator, but the hope was that by asking doctors to simply measure it and report it, Medicare could feed back to the doctors some report cards to them on how they were doing compared to other doctors. Outcome measures are even harder to measure, because for outcome measures, there's way more patients in the world than there are doctors and healthcare providers. So now we have to track down all of the patients and find out what happened to them. We have to count how many deaths there might have been. If there was an acute condition, how often was the condition cured? What was the readmission rate? For chronic conditions, how often did it flare up? Certainly is a lot easier with electronic records to track these outcomes, but it still is very data intense in order to make these measurements. I don't want you to think that only physical outcomes matter. Patient satisfaction gets measured as an outcome as well, because many of us believe that respect and dignity are what people want out of their healthcare system. So you may have already gotten one of these surveys where after you go to see the doctor, you get an email and you're asked to rate them on a 1 through 5 scale. This measurement technology isn't that perfect. In fact, it has a lot of problems with heaping, because a lot of patients would heap up about 90% of the responses as level 5. And very often the patient's reports of satisfaction are not about the technical quality of the encounter, but whether they had to wait a lot seeking care, or the convenience factor. So it's hard to detect differences if there's 90% of the data coming back at level 5. It's hard to know if there's a real quality measure. Another outcome measure that has come to our attention is the medical error rate. A medical error is something that can be detected by doing a chart review. By looking at a chart review, a reviewer can detect surgical complications, adverse drug events, incorrect diagnosis, incorrect therapy. It's a lot of work to do this type of calculation, because you need a trained chart reviewer from a medical record. So an important study done about 20 years ago from the Institute of Medicine calculated that medical errors killed about between 44,000 and 98,000 people every year and cost the U.S. health system $37 billion. This was an extrapolation from records in just 2 states where they reviewed 14,732 records. They found 459 adverse events and attributed to errors about half of the adverse events. So 3% adverse event rate, 1.5% medical error rate, showing that errors are quite common, and we need to go ahead with mechanisms to try to remedy this. One thing I think I can defend right now is my claim that the more it matters, the harder it is to measure. Structure gets measured the most, followed by process, followed by outcome. Measuring outcome requires detailed looks at 14,000 charts and outcomes and exit interviews. What do we want? Now, we could debate about the goals of the health system, how much we want improved health or improved distribution of health and so on. But I would argue that what we want most is the outcomes. And because outcomes matter most and they're the hardest to measure, we're going to have to get some resources to measure the outcomes that we care about in order to improve quality. I want to move on to talk about government interventions that try to help with quality. There are structural interventions that state and other countries' national governments undertake. So states license doctors and nurses and dentists in the USA, and states also license hospitals. So they are making this initiative. In order to qualify for your license, you have to prove that you've gone to medical school, gotten passed all your classes, and continuing your medical education. Federal payers do other interventions for quality. I've already talked about the Physicians Quality Reporting Initiative, but Medicare and Medicaid and the VA, as payers in the system, they can use their special status as payers to pursue quality. And if we taxpayers and voters vote that way, Congress can direct Medicaid and Medicare to do a lot more for quality. Medicare has already shown that it will deny payments for unproven technology. So if there is a surgical procedure that has failed randomized trials, Medicare will just stop paying for it and move the providers away from doing it because they won't get paid to do it. Also, because they are seeing so many different claims, Medicare and Medicaid can flag frequent flyers. Patients that are overusing narcotics can be flagged by federal payers, and they can be flagged by private payers as well. Another tool that governments use are courts and bureaucrats and inspectors. I have another lecture for you to see about malpractice as a way government set up an arena for quality assurance. The government focus does tend to focus a lot more on structure than on anything else. And if I would draw a diagram of the government mechanism, patients at the bottom are the recipients of care episodes, medical care, episodes themselves symbolized by M, and quality, which is the quality of the events that they get. So they get events like pills and surgeries and doctor visits, but they also receive the quality of the pills and surgeries and doctor visits. Healthcare organizations would do financing, sending money to the care providers, and the government can send financing to the healthcare organizations. Patients can send financing all the way to the top to the government. But the oversight for quality would come from the immediate healthcare organization, and the oversight for the healthcare organization would come from the government. So if we use government, we take tax money from the patients and we trickle it down into the system to do acts of measurement and correction of healthcare quality. Third principle I want to point out is that asymmetric information is a critical obstacle for quality. The person who cares most about your health is you, and maybe second to you is your family, third to your family is your employer, and last in line who cares about your health is your insurance agent. You're the one who cares the most because it's your body that's going to be hurting and getting sick and giving you misery. So if you who care the most cannot recognize and demand quality, then the ones who are outside of you, they're not going to make much money from you recognizing it for you. That's a major externality. So the business case that relies on our current payments driven by you demanding quality is broken because you cannot even tell perfectly how well the system is feeding you. You didn't go to medical school, and so you're in a tough spot trying to judge whether or not your healthcare provider is doing the appropriate thing. Certainly Google is worth more than nothing. It's better than nothing, but it has its limits because now the internet is full of conflicting advice on what the best form of action is, and it's difficult for lay people to navigate a Google search in order to get information about healthcare quality. Because of this brokenness, this externality, where the best agent for quality is not in a position to demand it, we really do demand a level of coordination above the providers, a coordinating body, let's say, a JCAHO, or a watchdog that is looking down on the providers to address access and quality. Now, government is something that we're talking about today, but non-governmental agencies also play a role here. This non-governmental agency could be a watchdog in the medical practice side of things. There could be peer review groups. There could be an association of medical practitioners, the College of Surgeons, the College of Pediatricians, let's say, could be helping to watch out for quality. Pharmacists can be watching out for quality. Private pharmacies often will monitor prescription quality and looking for medication errors. We talked earlier how the physician is motivated by a combination of a utility function depending on profit, leisure, and patient health. Quality does take away from patients' profits and leisure. It involves longer visits, paying more attention. A coordinating body can help improve the marginal utility to the physician of the patient health outcome. Simply by having physicians see how what they do affects quality, we could get the private providers to produce more quality. Coordination can incentivize better quality simply by collecting it, by going through the PQRI system and telling doctors how they compare to others. That would be an incentive to the physician's utility function. In other countries, there's actual payment for performance as a quality intervention. In the UK, the National Health Service will watch various indicators of physician quality and give them bonuses and top-ups for quality. At the bottom of the slide is the topic of engineering and designing in success. And building these systems of checks and balances in hospitals and clinics can really help. Most hospitals have a quality control unit, a patient safety department. Their job is to find out all of the near misses and definite misses. And when they find a near miss, they'll look for root causes that they can correct on a daily basis. These reviews lead to the identification of look-alike medicines and sound-alike medicines. And if you see that a medicine's name looks like a different medicine, that is a setup for a medication error, and the healthcare team can say, no, you're not allowed to write prescriptions that way, to use that fail-safe. So patient safety officers are critical. In the era of the electronic health record, the machine itself can flag these near misses and have a pop-up screen that tells the healthcare worker, there's a problem here, there's a quality problem, you better think twice, there could be an allergy, there could be a medication interaction, and this is a design factor that goes into building a safer hospital and a safer clinic. As far as will the market ever solve this, there's a perpetual desire for health economists to hope against hope that there is a business case for quality. Just as there is a business case for quality in other service industries, where if you are a very courteous restaurant with good food and good service, you will make a lot of money. Why doesn't that work in service quality in healthcare? Why don't we see hospitals and healthcare providers compete on quality? In theory, if you do a great job, you'll make your patient healthier, they would submit fewer claims, they would give higher satisfaction, and both the insurer and the hospital would be more successful if only they would have higher quality. The problem, as I think you'll see, is that the business case for quality becomes weak because, first and foremost, consumers do not have the ability to perceive quality differences that they need to. The second important thing is that there's a displacement of the payoffs to quality. If I work really hard to be a high-quality hospital or clinic today and make my patients healthy today, they might not offer financial returns for many, many years, or they might leave my health insurance plan within a few years. In some Medicaid systems like Baltimore, the mean duration of stay in a Medicaid HMO was less than 3 years. So there's a disconnection between consumers and payers. The consumers are moving in a different trajectory, and the payer can't capture the financial benefits from making them healthier. So let's review what we covered in this lecture. There are 4 principles of quality in healthcare. First principle is it needs to be measured. Second principle is that the more it matters, it turns out the harder it is to measure. The third principle is that asymmetric information is the number one deterrent to quality, and adding information is going to require resources, and that's what Principle 4 says, that those resources need to come above the private providers. They're going to be only part of the system. They need either governmental or non-governmental oversight watchdogs in order to measure the quality and give them an incentive and a signal that helps improve the quality. Now, the governments in some settings are not on the ball about doing this supply of quality. And in many low-income countries, the government simply is checked out of the quality of care side of the equation. And in many areas, we do desperately need non-governmental models of coordination and quality assurance in the healthcare field. This is an important public good, and it's going to suffer all of the public goods problems that we've seen throughout the course. We need to find a way to pool our resources and get consensus on how to pursue quality in healthcare. So that's all for now on the quality of care. Thank you very much.